like ammonia, all right? It's not, again, without a specific history, it's not going to necessarily be the first thing that pops into your mind that, you know, this is the problem, okay? And that's, again, why I think about it as being the next layer in your differential and in your workup. Obviously, in our current world, not only do we have to think about things that are intrinsic to the patient, but are things that are in the environment or interactions with the patient that can affect them, okay? So we're going to have to think about things like trauma, something that perhaps the person themselves, I mean, they could be responsible for it, but it could be external, all right? But you're going to think about getting a head CT, okay? If you don't have a strong history, by the time, or a definitive, you know, answer, by the time you get down here, then you need to start broadening your differential, thinking about things like, you know, tumor, think about, you know, infection specifically to the CNS system, and get a head CT, okay? You're going to get a CBC and cultures, all right? And that obviously is going to come before the head CT, hopefully. But, you know, in general, you know, we're not going to think about, without, you know, this bleeding being quite significant, something that you're going to be already suspicious of, all right? The CBC isn't necessarily going to be first line for making a diagnosis for change in mental status unless you have something else to pair it with, all right? You're going to get a blood culture, okay, a urine culture, okay, and if appropriate or applicable, a CSF culture, okay? Now, obviously, if you're working from the side of transport, you're not going to tap your patient at the outside hospital, all right? But it's something that you need to look for when you're gathering your information. Has this already happened, all right? And that way, you know what their thought process is, and you know what's missing, so that when you get to your destination, you can say, here's the workup they've already done, except for, you know, a spinal tap. They didn't do that, and that way that kind of gets everybody thinking on the same page. Okay. Whether or not to have a CT done before you leave an outside institution is something that should always be considered. Most of the time, in this day and age, we're lucky enough where even the smaller hospitals have the availability to do a head CT most hours of the night, so it's nice. Years ago, that wasn't always true, and they had to call someone in. It would be a significant delay in order to get that information. So we were faced with having to make the decision of, you know, is it better to wait until we know if this patient has, you know, a significant head trauma, intracranial hemorrhage, so that, you know, the minute they hit our door, neurosurgery could take over. Those days are pretty much gone, and like I said, most of the time, if, you know, they've gotten this far down in their workup, that they're, you know, most places are available to do that. But that can potentially be an issue if no one's thought about it. So that basically is what your checklist should be, okay? So when you guys go out and pick these patients up, my expectations are that you're not just passive, okay? You're not just going to say, okay, give me the patient, I'm going to do, you know, my ABCs, obviously, and intervene and take care of those things, and I'll just report whatever workup's already been done, okay? My expectation is that you actively look and make sure that all these things have been addressed, that they've been done, that you've looked at the results. You know, is there something that I need to start intervention now on, all right? If the patient seized, which is a change in mental status, all right, if the patient had a seizure and their sodium is 110, okay, then we need to start actively, intervening and correcting that en route. All right, not waiting until the patient comes back. The same is true with the calcium, magnesium, and phosphorus. All right, all those things can be addressed en route, and that is our goal. Okay, don't forget that. The goal is not just to bring the patient back safely, but the goal is to provide critical care level interventions from the moment that we get the phone call, and especially from the moment that we arrive as a team. Okay, so I expect you guys to, again, actively assess these things and use it as a checklist and make sure all these things have been done. If you don't have something specific in the history or that's been found initially to explain the change in mental status. And if the calcium, mag, and phos haven't been done, then you have to think about the options. Is it going to be faster to ask the outside hospital to add these things on to the sample that's already in their lab, and maybe you would have an answer before you get the finished packaging the patient, doing whatever you need to do, and you're leaving, or not, okay? And it just depends on where you are and the situation, and I guess the time of day and the staff that they have available. The drug screen may be a little bit more difficult, but if they haven't done it already and you're still looking for an answer, then the best thing to do is collect a urine sample at that point in time. Even if you take it with you, okay, make sure the lid's on tight, put it in a Ziploc bag and bring it with you. And the reason for that is the more fluid that you administer to the patient and the more urine that's cleared, theoretically can dilute the results, all right? In a short period of time, in a couple of hours, it probably wouldn't matter. But the earlier the sample's obtained, theoretically the better. What else? Obviously, it's always better to obtain cultures before the antibiotics are given, okay? If you're in a dilemma about the fact that, that they've just gotten the Cepha whatever up and, they're putting it on the syringe and they're starting to, run the pump, and right when you guys arrive, but they haven't done a blood culture, then yes, and if it's appropriate and that's where we are in the workup, then you need to do a blood culture right then and there. It does make a difference, okay? Obviously, it depends on the organism. If it's something that's highly susceptible, I mean, you could eradicate it with that first dose of antibiotics, and then we're left having to do empiric therapy for a, poorly determined amount of time because we don't know exactly what we're dealing with. So it'd be nice to have that blood and urine culture before the first dose of antibiotics. What else? So these are things that it doesn't take a lot of extra effort, all right, but it does take some focus, and it does take being actively involved and remembering, the real scope of practice that we're doing, and and to carry a checklist, all right.